Assalamu alaikum for everyone and good evening. And I'd like to thank you so much for you guys being here till now, regardless of the reason. And also I'd like to thank the organizing committee, especially Dr. Fauzi, for inviting me here. And now we will be switching gears from liver to something else. We're going to be talking about peritoneum and retroperitoneal masses. So I'd like to thank one of my colleagues, Dr. Jennifer Ayman, for sharing some of the cases with me. Otherwise, I have no disclosures. And in this presentation, I will be covering some sort of overview of peritoneal and retroperitoneal masses through discussing anatomy and lesion characterization through the contents, and also growth pattern of the lesion. And if you look at that diagram, you can see how the peritoneal, you can see the peritoneal cavity there, and you can see the retroperitoneum behind that. So you have peritoneal lining and the peritoneal cavity. But I want you to notice something really important, that we have this area, which is yellow there. This area is outside the peritoneal cavity. And we call this the pre-peritoneal space. And is it important? It is important, and I'm going to show you why. Because sometimes if you look at that fluid collection here, this fluid collection lies in the pre-peritoneal space. So if this fluid collection is infected, you don't want to spread that infection into the peritoneal cavity. If you're doing some drainage or putting a catheter there, so be cautious. Don't penetrate the peritoneal outlining so that you don't spread infection into the peritoneal cavity. And here is more diagrams of the color overlay over CT images. You can see the peritoneal cavity and the retroperitoneum. And the retroperitoneum has the anterior pararenal space, perinephric space, and what we call the posterior pararenal space. And you know the peritoneum has the peritoneal structures, including the bowel, and also including the solid organs like liver, spleen, but kidneys and pancreas are retroperitoneal. And if you look at the anterior pararenal space, the one with green, if you want to remember, this space has the GI structures. Pancreas, ascending, descending colon are part of the duodenum. And the perinephric space, the one in green, this one has GU structures, kidney, ureters, adrenal glands, and the renal vessels as well. And also remember to look at that, what we call the vascular space, that having the major vessels. And here, these fascial planes, you can read those fascial planes, and these fascial planes divide the abdominal cavity into the peritoneum and the different retroperitoneal spaces. And I mentioned the structures within the anterior pararenal, perinephric, and remember that the posterior pararenal does not have any organs. It's only fat, the one in yellow. And here is one CT image from a case with acute pancreatitis. And you can see here is part of the parietal peritoneum, or the root of the mesentery that separates peritoneal cavity from retroperitoneum. And you can see the perinephric fascia that divides or separates the perinephric space from the anterior pararenal space. And here is part of what we call the pre-peritoneal space. Hopefully you can see that clear fat and the thickened part of the peritoneal reflection anteriorly. And this sagittal plane showing the thickened perinephric fascia as well. And after knowing the anatomy, the second step would be how to differentiate between intraperitoneal and retroperitoneal structures. And by looking at these two examples, you can see this big mass, and you can see the ascending and descending colon are displaced posteriorly. This means the mass is coming from anterior, so it has to be coming from the peritoneal cavity. And in this case, on that side, the mass is pushing the ascending colon anteriorly, so it has to be coming from the posterior aspect. So this one has to be retroperitoneal. So the first one is intraperitoneal or intraperitoneal mass, and the second one is retroperitoneal. So talking about peritoneal and retroperitoneal masses, starting with the peritoneal ones, what we call primary peritoneal masses are very rare. It's more common to see peritoneal metastasis than primary peritoneal masses. And here is a long list of intraperitoneal masses. I'm not going to go through this. I'm going to show some cases. But for retroperitoneal masses, it's the opposite. So primary retroperitoneal masses are more common. And most of them are malignant. And the most common one is liposarcoma, it's about 30% of the cases. And the second one is leiomyosarcoma, about 28% of the retroperitoneal, primary retroperitoneal malignant masses. And retroperitoneal masses can be solid, and you have a long list of differential there, and they can be cystic as well, and another long list of differential considerations. Am I trying to confuse you guys with these long lists? No, but this is the reality, and we have to find some ways to find some sort of differential considerations regarding these big list of masses, either intraperitoneal or retroperitoneal. So we should look for some clues. Some of these clues will be the demographics, how old is the patient, young, adult, or old patient, and also male and female. There are some differences between different patients. And at the same time, the location, as we said, intraperitoneal, they are different from retroperitoneal masses. And also the organ of origin. If we can find the organ of origin, it's going to be easy. If the mass is arising from the kidney, it's going to be easy for us to classify it. And the internal contents, that the mass has fat or doesn't have fat, and the growth pattern, as we will see. So starting with tumor location, as I said, intra versus retroperitoneal masses, because this will affect the surgical approach, as we will see. And the organ of origin, sometimes we can find the organ of origin like easily, but other times, especially with big masses, we cannot find the organ of origin. And in this case, we should rely on other features. If we can find the blood supply to the lesion, or tissue pedicle, or sometimes if the entire organ is absent, like mass arising from the adrenal gland, and the entire adrenal gland is not seen. And by looking at that case, you can see a big mass here that contains fat and solid component as well. And many of us, when you look at this case, you would say, oh, it's very concerning for liposarcoma. But if you focus on this following image, and you can see that blood vessel, that's the vein that's arising from the kidney or reaching the kidney, and also the attachment of the lesion to the kidney itself, you can easily say there is a draining vein there, and this mass is most likely an angiomyolipoma, which was the case. It was not a liposarcoma, by just finding the blood supply or the blood vessel reaching that mass. And here is another mass, retroperitoneal one. It's difficult to see, and this mass is related to several vessels there, including the renal vein and the left gonadal vein as well. And this mass was a leiomyosarcoma from the left gonadal vein. And as you know, leiomyosarcoma is most of the time, majority of leiomyosarcomas arise from the extravascular. They arise from outside the blood vessels, because the smaller portion that arise from the vessel wall or from intravascular part, they are easy to diagnose. So be careful about the blood supply or the blood vessels adjacent to the masses. Here is one more case, and if you look at it, this is like an eye test. You can see this enhancing mass there. And I think any of us will be forgiven if we call this mass as a just gastrointestinal stromal tumor arising from the bowel. But if you keep an eye on the mass itself, and hopefully you can see, follow those arrows, and the mass with the adjacent vessel, and this vessel is the left colonic vein, and actually this mass turned out to be another leiomyosarcoma arising from the left colonic vein. And again, the surgery will be completely different, because if we call this as just, then the surgeon will be going in trying to look for bowel lesion, and they will never find it, because this mass is a retroperitoneal mass, and it's arising, as I said, from the left colonic vein, and it was a leiomyosarcoma. The origin also, if we can find what we call the neural pedicle, because in this lesion, it's a bright T2 signal lesion, enhancing as well, and hopefully you can see that pedicle there, and this was a schwannoma arising from the ilioinguinal nerve. And looking for the second step, the contents of the mass, and I think two major categories here, if the mass has fat or not. And if the mass has fat, then we're going to be dealing with liposarcoma and others, like mimics of liposarcoma. And those liposarcoma, I'm going to focus on angiomyolipoma and myelolipoma as well. And liposarcoma, as I said, it's the most common retroperitoneal one. It's about 30% of the cases. And if you look at it, huge mass, almost engulfing the kidney and reaching to the other side as well. Huge fat-containing mass, and most likely this is going to be what we call well-differentiated liposarcoma, because we have other types of liposarcoma. One of them is well-differentiated, and the second one is called dedifferentiated liposarcoma, and this one has more of soft tissue in addition to the fat as well. And you can see this is more like soft tissue, that part. And if you look at further images here, the mass has fat and soft tissue and also calcification. Those white spots there are calcifications. And these all are features of dedifferentiated liposarcoma. And sometimes it can be difficult, especially with poorly differentiated liposarcoma, to see these features, because poorly differentiated one may not have any fat. And it's going to be confused with other retroperitoneal sarcomas in general. But if you pay more attention, like in this case, we kept looking for this case, and we found a small fat component inside the lesion. This would make us to call it as a poorly differentiated liposarcoma. And the differential considerations for liposarcoma, as we said, fat-containing lesions, and these are two different cases, the one in your right and the one in your left. The one in your right was a liposarcoma, but what about this one? Here is a liposarcoma on your right, and what about this one? Does this remind you of the previous case? And we can see a draining vein, and you can see the attachment of the mass to the superior pool of that left kidney. So don't call this one as a liposarcoma. This is an AML, angiomyolipoma. And one of the lesions that may contain fat is retroperitoneal teratomas or teratomas in general, and hopefully you can see that lesion there in the retroperitoneum with fat and also calcifications as well. And this is a really interesting case, and hopefully guys pay attention to this one, because this is where we as radiologists can make difference. And if you look at this CT image here, and you can see this mass posterior to the psoas muscle displacing the psoas muscle, and it is fat containing. And here is the proof to you. We have in-phase image and out-phase MRI image, and you can see the significant signal drop denoting that the mass has fat. This means what? It's a fat containing retroperitoneal mass, definitely. We may think of liposarcoma. And to be honest with you, we have done the same with few more cases before that case. And actually 2 of those cases came back as extra-adrenal myelolipoma, and we learned our lesson, the hard way. Then we started to think about something else. And hopefully you guys are familiar with that image. Are you? Do you know what it is? And it's what we call, because I found like so many radiologists, actually of my colleagues, actually none of them were familiar with that imaging technique, and it's a sulfur colloid scan. And this mass was taking sulfur colloid. This means the mass has myeloid component, because liposarcoma will not take that, but myeloid component will take it in cases of myelolipoma or sometimes extramedullary hematopoiesis. Both of them will take that. And this means this is a benign lesion, and leave it by itself. Don't remove it. And the reason I said we learned the hard way, because our surgeons removed a couple of these cases before, and some of the cases came back as myelolipomas, extra-adrenal myelolipomas. So hopefully, when you see some of these masses, especially when they are very well defined like this, try to do sulfur colloid scan before you call it liposarcoma clearly, Especially if it's very well defined like this and it's not very aggressive mass, before even putting a needle there for biopsy. So calcifications, we talked about calcifications in retroperitoneum in general, but I'm going to mention one example in the peritoneal cavity, which hopefully you guys can see these calcifications here in the peritoneum, those kind of calcifications. And it's very common with serous ovarian tumors. You can see this kind of calcifications. But what about if there is no ovarian tumors? And this is what can happen with serous carcinoma, actually, like primary serous carcinoma of the peritoneal cavity in absence of ovarian tumors. And these tumors are common in postmenopausal women. And as you see, like they can come as masses, but calcifications are common with these lesions. And moving further, what about solid masses that do not have fat? Then we're going to look for other tissues like myxoid tumors, tumors that contain myxoid tissue, as we will see, or fibrous tumor, or hypervascular ones, or the pattern of growth. And myxoid tumors, as we will see, characteristically, myxoid tumors, they have very bright signal on T2 weighted sequences, very bright signal intensity. And the 2 main ones I want you to remember are neurogenic tumors and myxoid liposarcoma. And here is one of the lesions, bright on T2, heterogeneous enhancing lesion, and it was a case of schwannoma, retroperitoneal schwannoma. And here is a second case of myxoid liposarcoma. And please compare this mass to that huge renal cyst. It's very similar. Actually, attenuation value was very similar to the kidney cyst. Look at MRI. T2 weighted images, they're very similar to that huge renal cyst on the right side. But look at the post-contrast. Because if it is a pure cyst, it will not enhance. This mass is enhancing. It has some sort of delayed enhancement. So it has to be one of the myxoid tumors, which is commonly is going to be a myxoid liposarcoma or one of the schwannomas. The second thing is fibrous content of the tumor. And fibrous tissue has dark signal on T1 and T2, which is opposite to myxoid tumor, which is very bright on T2. Fibrous tumors are dark signal on T2. And we have some lesions here like mesenteric fibromatosis, very dark on T2, and they enhance. They have little enhancement, like intraperitoneal ones. And here is another big mass with mixed signal intensity, particularly along the periphery. Look at this dark signal intensity on T2. This is characteristic for fibrous tissue containing mass. And this has to be one of the fibrous tissue containing masses, and this came back as one of the fibromas or localized desmoid tumors, intraperitoneal ones. Necrosis and hyperenhancement, they go together because many lesions, even the hyperenhancing ones, if they are big, they will have necrosis. So smaller ones, they enhance homogeneously, but the bigger ones, they will have some sort of central necrosis and hemorrhage as well. And here's one, a huge mass from. What's that? You have done this, like I'm the first one to do it, but I'm going to cut down my next session. So this is a big or huge tumor arising from the stomach, and it was a GEST, gastrointestinal stromal tumor. And this is two enhancing masses in the retroperitoneum. You know, one of them for sure is going to be paraganglioma. We know that, extraadrenal paragangliomas. And the second one is very common as well, which is Castleman disease, the hyaline vascular one. And we have done MIBG scan with one of them that was positive. So this one was a paraganglioma, and the second one was Castleman disease. And growth pattern, you know, if the disease is diffuse peritoneal disease, we have a couple of them. And in the retroperitoneum, we have what we call mantle growth. And the mantle growth is really important, especially in the retroperitoneum, big retroperitoneal masses there in a case of lymphoma. And by mantle growth, we mean the lesions surround the structures without obliteration or infiltration. And the second case is an IgG, is a retroperitoneal fibrosis. And the third case was an IgG4 related disease. And one more case here, and this is really important for us as radiologists. When you see this big retroperitoneal masses in a young male patient who was 29 years old, you have to think of testicular masses, because this can be easily metastatic lesions from testicular tumor, like in this case. So whenever you have this big retroperitoneal masses in a young male, do testicular ultrasound, and the opposite way as well. If you see a testicular mass in a young patient, do CT abdomen pelvis for staging. And here is another case of masses infiltrating or surrounding the kidney with deviation of the ureters like medially. It was a case of IgG4 disease, related disease. This was a very unique case, a lot of masses around both kidneys and extending along both ureters. And actually, personally, I call this as either IgG4 or lymphoma case, but the patient had history of prostate cancer, and surprisingly, it came back as prostate cancer metastasis, very similar to lymphoma and IgG4. Hopefully you guys are familiar with Erdheim-Chester disease. It's very similar disease, infiltrative process around the kidneys, but also they have other manifestations because it is a systemic disease, like sclerosis in the diametaphyseal, as you see here in the bone scan. Cystic masses, I have two interesting cases. One of them is very straightforward, like lymphangioma, huge lymphangioma, and as you know, lymphangioma does not respect the tissue boundaries, and this is a really interesting case. This was young female, she was pregnant, 12 weeks pregnant, and she has this kind of cystic / solid mass in the retroperitoneum, and it was going also into the pelvis. And we were not sure what kind of mass is this in a pregnant lady like this, until the patient during admission had some chest pain. Then we got a CT chest for assessment, and we found like so many cystic lesions in the lungs, and also tiny pneumothorax here in the right apex. This is typical for LAM, right? This kind of changes in the lung in a young female in this childbearing period. So then we thought, you know what? I think the changes in the peritoneum as well was a leiomyomatosis as well, because we were unable to give contrast because of the early pregnancy, like MRI contrast. This is a peritoneal inclusion cyst, typically, you know, especially with endometriosis. And you can see this patient has endometriosis, as you see. And lastly, like, you know, when you look at those solid lesions in the retroperitoneum, think of fat, no fat, and then look for other tissues and the growth pattern as well. And for peritoneal lesions, the same idea, look for them focal or diffuse and other features as well. And the last one for cystic peritoneal, retroperitoneal lesions. And summary-wise, you know, step by step, differentiate between intra and retroperitoneal, look for the relationship with other organs like blood vessels and so, like blood supply and other manifestations, solid and cystic, and all these features can help us to reach like a final diagnosis. Thank you so much, and sorry for that few minutes extra. So thank you.
For this nice presentation and nice cases.